And it's time for the cases. And I would like to take this 15 minutes to accomplish two tasks. First, to present the two interesting cases for you of fatal arrhythmia, and also to review the ways how we can assess the cardiac rhythm, especially in preparation to our hands-on demonstration after the break. So just want to remind you that ultrasound-based techniques for assessment of the fetal arrhythmia, these have the most clinical application, and there are several advantages to that. So the techniques that we are using mostly used based on the simultaneous recording of the ventricular and atrial events during the cardiac cycle. So that also allows the assessment of the anatomy of the heart, and we can reveal the coexisting cardiac structural defects. And it's very important to remember that you are doing ultrasound assessment of the heart for the rhythm problems, that we are looking at the just mechanical events, that they are reflecting the electrophysiology, but not directly at the electrophysiological events that occur in the muscle of the heart. So it always starts from the assessment in 2D and screening of the fetal echo. So, but 2D just gives you the overall feel that this heart beats slow or fast, and definitely you need the more objective orientation in assessment. So classic M mode needs to be used based on our guidelines for assessment of the heart rate, and usually we need to position the M mode the way that the cursor crosses the myocardium of the ventricle and the atria, and we can visualize the contractions of the ventricular wall and the atrial wall. Unfortunately, not always the baby can behave for us the way that we can do that. So this is the anatomical M mode using one cursor, one line or two as presented here can come to rescue. And the way how we evaluating that the cursors ideally should be placed way that to pick the maximal amplitude of motion of the myocardium, and again in this lateral position of the four-chamber view, so application of two lines or one steering line, that would be very beneficial. So this is the example how we can use just one anatomical M mode line to improve our imaging. Sometimes we deal with the very difficult cases, so we can use the combination of the M mode and color Doppler to achieve the better results. But we can also switch to the techniques that utilizing the spectral Doppler. We can use two vessels usually, one of the venous vessel and another one is the arterial vessel to demonstrate the atrial and ventricular contractions. This is the example of the historically developed method first that utilizes the aorta and superior vena cava. We can do the same, then we look at the simultaneous registration of the blood flow patterns in the left brachiocephalic vein and in the aorta. So you can see that the brachiocephalic has a little bit of reverse flow during atrial contraction, so this is the peak that we can actually utilize for measurement. The place I was trained in Germany, this Professor Gambroch, they developed the technique that utilizes the renal vessels, the Adrian vein, for the assessment of the cardiac rhythm. This technique is in particular helpful in the late third trimester. Then the visualization of the heart itself could be very difficult, in particular if you do the assessment within the obstetrical settings. The same approach can be used, then we look at the pulmonary arterial vein. And once again, the venous flow in the pulmonary vein would demonstrate the atrial contraction right here. And so that's the ventricular contraction can be judged based on the blood flow in the pulmonary artery. We can look at the blood flow in the left ventricle outflow tract. This is the technique that utilizes that favorable anatomy of the left ventricle that allows demonstration of the blood flow, like inflow and the outflow at the same plane, and the five-chamber view would be ideal for that. or we can switch to the tissue Doppler technique and place our sample volume on the side of the tricuspid annulus, and we can obtain curve like this that demonstrates direct motion of the muscle of the heart during cardiac cycle. So if you work in the pediatric cardiology settings, you can utilize this technique that was very nicely highlighted and published by Dr. Hornberger recently, that we can place two sample volumes separately on the atria and the ventricles, and that could be a very great technique to help the evaluation of the heart rate. So I would like to present all those techniques just for the sake of diversity of the methods that we can use. And there is no ideal method, but it's very important to remember that several tools are available, and usually using the combination of those techniques help you to arrive to the correct diagnosis. And I will hope that show you more of those methods during the hands-on after break. So here is the first case. The patient was referred to us that her first pregnancy, uncomplicated pregnancy, that on her evaluation during morph scan around 19 weeks, 20 weeks gestation, the heart rate looked a little bit slow, regular, but kind of slow. So this is our evaluation at 23 weeks gestation. You can see that the anatomy of the heart looks okay. We can apply color Doppler and look at the combination of the grayscale and the color Doppler. Nothing really stands out. We looked at the outflow tracts. This is a perfect assessment of that. We can look at the right ventricle outflow tract. Again, nothing really suspicious, and the three vessel and trachea view. But during the entire exam, we took the heart rate several times, and the heart rate was assessed very accurately. We were not able to get the heart rate, ventricular rate, higher than 120 beats per minute. And the range was observed in between 109 to 120, but again, it was absolutely fixed at the same number. And here is another example. Then we used a different technique utilizing the pulmonary veins blood flow, and again the heart rate is 118. So we measured some PR intervals, and then we observed this pregnancy over time, and you can see here, this is the graph of the normal heart rate that Dr. Conneal presented in her presentation. So this is exactly the behavior of the patients, the suspected long QT syndrome, so that the heart rate is above 110 as an average, but it's definitely below the third percentile for the gestational age throughout gestation, no matter how many times you take that heart rate. So we recommended her obstetrician to deliver the DAS rather than in their office, but they said that this is something that they absolutely can handle. So we suspected the sinus bradycardia, the suspicion of the long QT syndrome. So the baby was born at term, the good UPCARs, but then the very same day, the heart rate dropped to 60, and the patient was rushed to the children's hospital, where the postnatal electrocardiogram was performed, and they documented the long QT interval based on the changes on the electrophysiological study. So this is the overview of the long QT syndrome. So this is problem, the elongation of the QT interval on the electrocardiogram. There are several genes described for that, like up to 17 genes, but the most common, this is a long QT type 1, 2, and 3, related to those genes that presented here. And so the most common presentation of the long QT, this is the sinus bradycardia. And it also could be a family history, but in our case was what was really remarkable, that through this fetus, we diagnosed the entire family, and this is our infant and a little child. Who actually, through him, we diagnosed another 14 members in the family who had the long QT and had no clue and had a high risk for sudden cardiac cardiac death. They all were placed on medication since that first pregnancy. The patient returned the second pregnancy, and the same changes were noted. And we diagnosed the other baby after birth with a long QT as well, so that the inheritance is autosomal dominant. Penetration can be different, but this is something that such a small change on your screening OB exam can result in such dramatic consequences for the families, and I strongly believe that we saved the multiple lives by diagnosing that. So the second case that I would like to present here was a little bit easier because the patient came with a confirmed personal history, confirmed genetically, of the mutation at the same gene, but of the different kind. So indeed, she was diagnosed as a short QT syndrome, so that the mutation in the same gene may occur that result in the loss of function, as in the case of the long QT, or the gain of function, as the case of the short QT. So the short QT is a much rare condition, and in her case, she was diagnosed through her son, who at age 15 just passed out on the football field, and so went in the cardiac arrest. And this is how the mutation was discovered in the family. The interesting fact that now we just had him having a baby with the spouse, and so that baby also was diagnosed as a short QT. So like this runs in the families, and it's important to remember about that. So here you can see the change in the heart rate of that patient, and you can see that in contrast to the first case, we were able to observe that the heart rate on the baby was more like described as the sinus tachycardia, and again subclinical, because most of the time we were registering the heart rate that was above 97th percentile for that gestational age. So in here you can see again the perfectly normal four-chamber view, but the heart rate is higher. It seems like the heart rate is racing, and the lowest heart rate that we were able to achieve during the entire pregnancy, and we're measuring that on a regular basis, was 157, the highest being around 190. So in here you can see the average rate of one-to-one conduction and average rate of 167. So the patient had induction of labor, 39 weeks gestation, uncomplicated delivery, and after birth was confirmed having that mutation typical for the mom and the brother. And this is the postnatal finding, confirmation of this short QT by electrocardiogram. So here is the conclusion that similar to the long QT, the short QT is a rare disease. In this case, we had the mutation in this KCNQ1 gene. And again, it's associated with the gain of function of the cardiac potassium channels and belongs to the channelopathies. So again, it has the autosomal dominant inheritance, and it's important to remember that the long QT and the short QT can present with relatively minor changes of the heart rate that can be detected on prenatal ultrasound, such as the borderline sinus tachycardia or bradycardia, but it's very important to follow and see any abnormal findings in the family history, for example, like sudden cardiac arrest or sudden cardiac death on the relatives at the age prior to 40, and doing the surveillance, and in particular a very close follow-up for the heart rate surveillance in the third trimester is highly recommended, and delivery should be considered. We need to be conservative, and if it's suspected, so we need to recommend delivery in the centers with the expertise in the management of the arrhythmias of the neonates, and also where the electrophysiological studies are available. Thank you very much for your attention.